Hello, everyone. My name is Gina Jackson. I am Western Shoshone from the Timoke Band, born and raised in Reno, Nevada. I work for the National American Indian Court Judges Association as the program director, and this webinar, Opiate Addiction in Indian Country, is one of a webinar series. So just heads up that there are more exciting webinars to come, and we would look forward to having you join us in the future. I see lots of familiar names of colleagues and friends in the chat box, and I look forward to hearing your thoughts as we go through the webinar. The format of this webinar will include three amazing experts, and I'll introduce them in a moment. Then during the webinar, you can ask questions, and we will also reserve time at the end of the webinar exclusively for questions and answers. So if you think of something later, just make a note, and you'll have a chance to ask those questions towards the end. So to get started, let me introduce our three presenters. First, I'm going to introduce Judge Kim McGinnis. Judge Kim McGinnis is the Chief Judge of Pueblo of Pojoaque. She has a PhD in neuropharmacology from the University of Michigan and completed a postdoctorate fellowship in molecular neurogenetics at Massachusetts General Hospital. She graduated from Boston University School of Law in 2004 and has worked primarily as a criminal defense attorney until 2011, when she moved to associate judge in 2013 and chief judge in 2015. Judge McGinnis presides over Pojoaque's Pathway to Wellness Court, a Healing to Wellness Court, and is also the programmatic director of the recently implemented Sober Housing Program, which coordinates the Path to Wellness to provide structured, sober, transitional housing for people who are struggling with addiction. We also have two other fabulous presenters today, Dr. Anna Helena Skinstad. Dr. Skinstad is both a clinical associate professor in the Department of Community and Behavioral Health at the College of Public Health at the University of Iowa, and also the director of the National American Indian and Alaska Native Addiction Technology Transfer Center at the University of Iowa. Whew, that's a long one. She's amazing. She specializes in substance abuse and its intersectionality with the Native American populations. The National Native American Indian and Alaska Native Addiction Technology Transfer Network's goal is to disseminate and facilitate the adoption of culturally legitimate evidence-based practices to providers in the workforce using recognized state-of-the-art technology transfer principles. And we also have Sean Baer from the Meskwaki tribe. He is a certified alcohol and drug abuse counselor and a consultant for the National American Indian Alaska Native Addiction Technology Transfer Center Network, and specializes in substance abuse related to topics including screening and assessment and treatment. The national network's goal, again, is really to facilitate the adoption of culturally legitimate evidence-based practices. And so we're so excited to have you all here today, and I'll go ahead and hand it over.
Dr. Skinstad, we're having a hard time hearing you.
Yes, we had muted ourselves, and I apologize for that, but we are back. I hope you can all hear me. I really would like to thank you for inviting us to talk about opiate addiction in Indian country. And I know that having worked with Sean on this for many years, and also with tribal communities for close to 20 years, I am very honored to start working with tribal courts, and especially healing to wellness courts. So thank you very much for inviting us. As you can hear, I have an accent. So I'm not a tribal member, but I am born and raised in Norway and have lived in this country for close to 30 years. I just wanted to briefly give you an overview of what we plan to talk about today. And of course, we're going to talk about opiate and the drugs of abuse and treatment and prevention. But we also want to share with you some ONDCP action plan, the 4 pillars of an action plan, and examples of tribal initiatives that we have seen started based on a symposium we did on the topic in 2012. Of course, we have to say that the National American Indian and Alaska Native ATTC, we are speaking for ourselves and not for our SAMHSA, because we may have deviant or devious different opportunities and examples of experiences than SAMHSA has. We are part of a larger network, and this is what the network looks like. And all of you are residing in a state somewhere, and I'd like you to look and see what your regional ATTC looks like and what states they are serving. And I would really like to encourage you to connect with your regional ATTC for specific training, technical assistance opportunities in your region. And here are our specific mission, which is to be a national subject expert area and support behavioral health providers in adopting culturally informed and also experience-based treatment approaches to behavioral health disorders. So we work very much with the workforce. So let's switch gears to the topic for today: prescription drug abuse in tribal communities. We are talking about abuse or prescription drug abuse, and we have seen the beginning of an epidemic, I would say, where we started using a little bit too liberally very addictive painkillers prescribed by physicians, and then or any other kind of professional with prescription privileges, I want to add. And we have seen misuse and diversion, and what I'd like to highlight that we have seen specifically is the last bullet point here, that people help themselves to medication in their parents' medical cabinet, or if you have a guest you don't know that may be stealing. In other words, we've seen more of this recently than we have before. And now we have pulled up a poll question that I'd like you all to look at and see if you can vote a little bit. So we see a little bit on your attitude, knowledge, experience from your community.
Right, and it looks like it's pretty typical of, this is Judge McGinnis, of Indian country in general, that's having a severe problem with opiate abuse. Most folks are going to be having that severe problem. Yeah, so it looks like about 75% of you have a severe problem, and which is not a surprising statistic for an audience of this kind of a webinar.
And I agree with you, Judge McGinnis. The problem we have often when we are working in Indian country is that we don't have clear statistics on this for very many reasons, because of lack of reporting to IHS or to any official organization. So 35% seems like a reasonable percentage, but it may even be a little underreported if we think about what it looks like out there. What are your thoughts, Sean?
Well, a lot of times what I've seen is that many of the tribes where we have gone to, a lot of them are skeptical of, GIP reforms. They're skeptical of surveys, and sometimes even their tribes have told them not to participate in those.
Yep. And we understand why, but that makes us a little bit handicapped sometimes when it comes to stating the extent of the problem. I'm sure all of you online have seen and heard about what kind of opiates are being used. And we also know that from morphine and codeine, sometimes people go on to use heroin. And what is the concern that we have is that when we are prescribed necessary painkillers, they are really supposed to be used on the short term, not the long term. But we have seen that oftentimes when people get prescribed oxycodone or hydrocodone, it results in use over longer period than we should have started prescribing it for. And what I also would like to highlight is that we prescribe these drugs for pain and for muscle relaxers, and gabapentin and Lyrica are newer. I shouldn't say gabapentin, but Lyrica are more recently developed medication, but our clients can abuse anything, even though it may not be intended to be abused. And I know that Judge McGinnis had some experiences with that, so I'd like to hear you add something to this.
Well, what we've been seeing recently is an increase in, or at least our increased knowledge of abuse of gabapentin, because it seems like physicians aren't realizing that people can abuse gabapentin. It does create a high. Some people describe it as a marijuana-like high, and it also will enhance folks who are on Suboxone. It also enhances the high, or it prolongs the high. And at this point, we haven't identified a test for it, so we've been unable to detect folks using it, but we know that people are using it as a drug of abuse to get high. And we're seeing it more commonly, and partly because we can't detect it with our tests that we currently use.
Mm-hmm. Thank you very much for that, because if you look at some of the advertisement on TV for Lyrica, there are reference to the potential of abuse, but I haven't heard that when it comes to the gabapentin. So you're right, this is something that we need to look out for. Another type of medications that very often are abused are the medications prescribed for anxiety disorders like benzodiazepines. And every time I hear somebody referring to a miracle drug, which was what they described the benzodiazepines like when they came, I get very suspicious, because that often results in abuse. Of course, we have also the selective serotonin reuptake inhibitors, the SSRIs, mood stabilizers, and even though those, as professionals, we didn't think could be abused, of course our client have abused them. But again, I'm not sure we have tests to detect that, other than we will see the level of that in the blood when we analyze blood tests. ADD or ADHD has been treated with stimulants, Ritalin, for years, and of course we do know that that is often diverted and also often abused. What we see, and we need to always think about when we work in Indian country, is that post-traumatic stress disorder often is expressed through pain, and being prescribed a medication for pain, oftentimes referred to also for as fibromyalgia. And what we know is that a lot of our clients in Indian country have experiences of domestic violence, being victim of violence, and having experienced what we call cultural violence, having experienced that things are taken away, not allowed to be expressed, etc. And that also, in the long run, creates pain. Physical disorders like cancer, pain conditions do need specific pain relief. And oftentimes we don't worry so much about abuse for cancer because those medications are very necessary. But what we as professionals need to think about is that there is acute and chronic illness, and opiates often or should only be prescribed for acute illness.
Okay, also looking at PTSD, especially with Native Americans, we need to look at trauma itself. You know, has there been trauma in the earlier in life within the family? Remembering that trauma can be passed down to other generations, but also leads to historical trauma. When you're working with historical trauma and trauma itself, PTSD, we also remember that these things can be compounded upon each other. So when you're looking at something like this, remembering that helps you to look at the whole picture and not just look at one.
Thank you.
And to remember that almost all of the addicts who are going to be court involved have trauma in their past, so whether they're willing to admit it at the early stages of their recovery or not, but usually you see them coming more and more out of their shell and admitting their trauma past, maybe just privately to their counselor. So it's coming from you have to come from a perspective of what happened to you that led you to where you are now.
Mm-hmm. And I think as a professional, it's oftentimes necessary to remember that, like Judge McGinnis says, it takes a time before our clients feel comfortable admitting to the trauma and the pain that they have experienced through the many traumatic experiences they've had. But these prescription drugs have a very high addiction potential. Tolerance develops very quickly, and that means that you have to have more for the same kind of pain as you had were prescribed in the beginning. That means also that there is a withdrawal symptoms that people need to be prepared for. And I want to bring up the concept of cross-tolerance. If you have a client who has been abusing alcohol and have an alcohol problem, they have developed a tolerance for alcohol, but that crosses over to opiates. So when you are prescribing opiates, they may need more to get pain relief. Mm-hmm. And that is at the beginning of what I would say is addiction potential to other substances than where they started.
Yeah. So then with addiction potential, we also want to look at, especially with painkillers, is pain itself. In some of the studies that they've had in the past, they talk about the threshold for pain, how much pain somebody can take. It has been questionable whether natives can take more pain or not, but that's kind of what's believed around. I've even seen that in Germany. Also, the lower pain sensitivity is that they're able to feel the pain earlier. And part of that, looking at somebody who can feel pain early, would also looking at the medication. Of course, they may need pain medication or something like that, or have that sensitivity more than others may. Also, with addiction potential, is looking at drugs, substances that have a quick onset and short duration. It's been associated with addiction potential because it starts out really fast, it ends really quick, and the people need to use again to get the same effect. But over time, what happens is you get neurotransmitters, brain changes within the brain where things begin to kind of shut down. In order to get the same effect, they have to use more or change to a different substance.
And I see some of you on the chat are referring to trauma-informed care. I think that's a very important point. It's something we as professionals working in Indian country need to think about all the time and take for granted that it's something we need to address. Consequences of abuse. We are first going to look at opiates that may be taken in large amounts, and I'm sure you all as professionals have seen them experiencing a drowsiness, being confused, being nauseated, having depression of your breathing potential, and with high dose that can lead ultimately to death. I want to also remind ourselves that when we are dealing with a person who has addiction issues with other kinds of medications or drugs and get a pain situation, a physical trauma, that usually is something that physicians need to really watch carefully. And the withdrawals, yes. Here are some examples of benzodiazepines that also are categorized as central nervous system depressants. And there's one thing I want to highlight here, that's barbiturates. That's a medication that isn't as often prescribed anymore, but is very dangerous and was the anti-anxiety medication used before the benzodiazepines were introduced. When someone is on any of these barbiturates, it's very dangerous to withdraw outside of a medical facility. And again, consequences of abuse, and we've talked about the tolerance, we've talked about abuse potential, withdrawal, and withdrawal from benzodiazepines as being very unpleasant. And as we said, also barbiturates very dangerous to withdraw from. Judge McGinnis, you have something you wanted to ask our participants about.
Right, so I think we're going to have an open-ended question, so if you could just respond in the chat. We were just talking about what are the consequences of abuse that you're seeing in your community, and just, I know you all have been chatting a little bit about this already, but we just want to kind of get a feel for what you are facing. Of course, one thing that we face a lot in Pojoaque and in northern New Mexico is the increase in child protective service involvement, children having to be removed from homes at much greater rates than they have been in the past, and then of course all the consequences of that with the family, and also trying to find appropriate foster families. And one of the things I wanted to mention at this point is, as coming from a background in pharmacology and now being a judge, presiding over a wellness court, when somebody's withdrawing, what you're seeing is they're extremely anxious. And so they're going to be very difficult to deal with because all of their brain energy is going towards figuring out how to stop being in pain from a withdrawal, or the anxiety around where they're going to find their next hit. So when you're talking to them in court, or you're talking to them as a professional, they're probably not actually taking in anything because their brain is at a point where they're not really able to learn or experience what they're going through in a way that a non-addict would experience, or somebody who's already recovered from their addiction, because it takes so long for the brain to heal. And so when I'm in court and I'm talking to somebody who's 3 days sober from heroin, they're not going to remember anything I'm telling them. So we're getting some responses. The neonatal abstinence syndrome, of course, lots of crime and abuse. The elders are the affected because the medications are being stolen. That's a huge, huge deal.
Yeah.
Well, the other aspect of it is when we're thinking about enforcement and we're concerned about abuse and we really crack down on that prescription drug writing, there could be people who need it that are kind of falling through the cracks there because doctors are not going to write prescriptions anymore because they're worried about all of this stuff. So I think there's twofold happening for the elders.
That's a great point.
Yeah.
Well, that's something we need to look at, remembering with opiates and heroin, painkillers and such, is many people have described coming down from heroin and opiates is that it feels like they're going to die. And so I'm sure just that fear alone is going to want to make them use. But also remembering that those drugs that are more depressing, when people are going through withdrawals, everything's going to be the opposite, and it's going to rise up. Heart's going to go fast. Everything's going to be speeding up.
I really appreciate all your comments here that we are reading about, and I am very sympathetic to the concerns for the elderly. I want to add one thing about that too, and that is that people who are older will respond to these medications differently than what we see in a younger generation, and oftentimes they will be confused. You will see other things that makes you very concerned about your elder, and there are reasons to be concerned. I also appreciate your comment to, concerns about drug-exposed newborns, children. And then I want Judge McGinnis to also address the fentanyl and the carfentanil issues.
Right. Well, we've been seeing a lot of fentanyl issues in northern New Mexico. Our officers just, a couple months ago, they intercepted a shipment of about 3,000 pills that were made to look like oxycodone pills, stamped and everything with the right numbers, but they were actually fentanyl. And fentanyl is an extremely strong opioid, and it's leading to in 2016, more people died of fentanyl overdose than of heroin overdose or of prescription opiate overdose. So it's becoming a huge problem, and it's easily smuggled and manufactured from Mexico.
Mm-hmm. And the first time I saw reference to carfentanil was actually in a newspaper in Maine. And I had never heard that medications that were used in animal care had been abused by our clients. But in Maine, that's the case. I don't know if any of you have experienced similar things.
Yeah, so looking at that is like fentanyl and carfentanil. It doesn't take very much for its effects to show. It's like even just a few granules can kill you.
Yeah.
There's also some evidence that fentanyl and carfentanil can be absorbed through the skin.
Oh.
Right. It's extremely dangerous for law enforcement too.
Yes, yes.
Can you elaborate a little bit about that?
Well, if they're getting there was a recent one where there was a whole shipment of fentanyl in a barrel where the officer opened the barrel and inhaled some of the fentanyl. They were able to get him medical treatment in time, but that's a situation where law enforcement could OD accidentally from exposure to very small, as was said, a few grains of fentanyl can be enough to cause an overdose. So our law enforcement who are searching folks or searching shipments can come across it, so they need to be extra careful and use masks and gloves.
Yes, there's when one police officer, they got it on their clothing, and when they brushed it off, they got it on their hand.
Oh, that I didn't even think about that. Obviously something we need to prepare our first responders for, and police officer, even firefighters, if they are working in a situation with a house that has fentanyl in the house. Okay, let's go a little further. Do we want more? You guys are really providing a lot of feedback to us about this. I just want to remind everybody about the CARA Act of 2016. I'm not going to go through it, but I want you all to be very aware that a lot of the CARA Act is focused on the opioid epidemic, and a lot of money is going to different parts of the professional environment to help with new programs for opiate addiction. And why are we switching to stimulants? For those of us who are old enough to remember, there was something called powerballs and speedballs, and those were a combination of opiates and cocaine stimulants. And I don't know if there are anybody online who've experienced that. This was very common in the 90s with the 80s, 90s, when cocaine and methamphetamine became very prominent. And we've already discussed this about how stimulant use is used for ADHD, narcolepsy, and sometimes depression. And some of the stimulants used are the Ritalin, the Dexedrine, the Adderall. And here are some of the consequences of abuse that I'm sure you all have experienced. What I want to highlight is the issue of psychosis, because a lot of times people who are abusing stimulants, cocaine, methamphetamine, tend to be very paranoid. And we have also seen different communities have an increase in aggression after some of these communities have seen an increase in stimulant abuse. I want to also highlight specific issues for women, and I see a lot of you are concerned about how opiate abuse influences women and also children, and remind ourselves that for a lot of women, substance abuse is still shameful, so they prefer to go to their medicine man, their clergy, their doctor, rather than substance abuse treatment. And unfortunately, women are often prescribe painkillers, and more often than men. And what I also want to remind all of us is that women tend to have more co-occurring mental health disorders than men. And we need to remember, of course, like you have experienced so many times, their responsibility for children and dependent other family members, and how they live in poverty and try to take care of their families is sometimes something we need to be really very impressed with. Treatment of women. I want to highlight one specific thing here, and that is that it's important to make sure that if an opiate influenced or addicted woman is pregnant, it is important to make sure that she has control over withdrawal symptoms, and it's recommended through research that withdrawing her from opiates while pregnant can have very detrimental effect on the unborn child. It is controversial, but it's something that we need to think about. Another group that I really would like to highlight is our native LGBT Two-Spirit tribal members. They often have a high prevalence of bullying and have experienced what did you say?
Victimization.
Victimization, sorry. And I'd like us to really hone in on the fact that young men who have sex with men, they may not identify as LGBT, but that is the group with the fastest growing prevalence of HIV/AIDS in the country and needs specific care. And of course, we know that this group of clients are vulnerable in the justice system. So let's switch gears a little bit and talk about prevention and treatment. Prevention issues. And we're going to talk a little later about It Takes a Village. Prevention really is focusing on how can we build awareness of what it means for a tribal community to have people dependent on opiates. Make the community very conscious and aware of what this means. You all have mentioned the elderly. This is a very important group to look out for. And we want to use the concept of recovery-oriented system of care. In other words, thinking about these disorders as chronic and needing support from a whole set of agency, not just one.
And also, when you're looking at recovery-oriented systems of care, considering other people beyond the professionals that we normally see in different offices. So we're looking at, maybe people who work within the tribe, tribal members who work on artwork or beading or some kind of thing like that, or looking at baskets, medicine people, healers, spiritual people who are willing to get in there and help with this. Sometimes those might be people who you might go to for sweat lodges or more traditional care within the community.
Mm-hmm. Mm-hmm. And of course, we want to work with healthcare professionals and direct them towards the CDC rules for prescription of painkillers. Talk to our patients about tapering off after the acute care, and that way try to reduce the prescription opiates. I think that we had a couple of poll questions that I know Judge McGinnis wanted to use.
Right, so there's
here.
A poll question about access to naloxone. Now, naloxone it's also known as Narcan. It's used if somebody is in an active overdose first responders have across the country are being trained to use naloxone to prevent prevent overdose deaths. So we wanted to see how prevalent it is in your community. So if you could answer that question about naloxone. And that's just used to prevent overdoses when somebody's actually overdosing. And in Pojoaque, our officers were just trained on naloxone, and they do carry Narcan now. Looks like quite a few of you have first responders carrying naloxone, which is great.
Mm-hmm. I'm very happy to see this poll like this because there are some states where this is not accepted, and with the caveat that this is just Band-Aid. But from a public health perspective, yes, we know it's saving lives and it's not necessarily taking the substance abuse problem away from this client. But with a situation with an overdose, from a public health perspective, we talk about a teachable moment. It's a moment where we can start motivating the client to do things with their substance use disorders. So thank you very much for this polling.
I see there's a question about,
okay.
Is the training available to learn more? Do either of you know about trainings for naloxone? I think that we can get back.
Yeah, I think that, but I want to direct those of you who are interested in this to some of the ASAM group's training and also the National Council training. But I think we need to sort of check in on this a little bit more and give you some update later.
Okay.
Thank you for that question, though. And here are some of the signs of the overdose. And some of these signs, as you can see, are very, very serious and have fatal outcomes. When it comes to treatment of opiate addiction, I think it is very important to think about it in two phases. We want the acute treatment to take care of what happens when people are in withdrawal and make sure that they don't leave us. And then you have the long-term treatment that are much more long-term, can be for years.
Yes, and many substance abuse agencies, they kind of base upon abstinence, no use at all. So sometimes that might be the end goal, but we need to remember that in some cases they can't just stop.
Right,
No.
and in the wellness court model, I think it recognizes that addicts can't just decide to stop. If they could decide to stop, then they wouldn't be court involved, and we wouldn't have the need for wellness courts and so much support for them as they go through recovery. And so I think it's important also to talk a little bit about harm reduction, with abstinence eventually being the goal, but you got to start with where the addict is at. And it's really hard for somebody who's an opioid addict to go cold turkey. And using medication-assisted treatment is certainly a good step. And actually, and I'm sure Dr. Skinstad can back this up, that medication-assisted treatment is the only thing that has actually been shown to work with opioid addicts. So, in wellness court, we celebrate the baby steps, that the person went 3 days without relapsing, and that's the longest they've ever gone without using heroin. So we celebrate that as a harm reduction, and we don't necessarily, throw somebody in jail or kick them out of the program for a relapse, because of course they're going to relapse. And relapse, we say in our program, relapse is part of recovery, and as long as they're learning from their relapses, we keep moving forward.
Mm-hmm. And 1 to 3 days without opium can often lead to 4, 5, 6 days. And the longer somebody is able to experience what it means to be without the substance, the more we know that they will be able to succeed. And as Judge McGinnis was saying, medication-assisted treatment is absolutely necessary for successful outcome. And we have many, many years of research in support of the use of methadone, and also in recent years, support of the use of buprenorphine. However, if you combine that with psychosocial treatment, talk treatment, that is when the treatment results are going to be even better. And here you see also the long-term treatment effect is going to be better with the use of a combination of buprenorphine and therapy, or methadone and therapy. But of course, with the buprenorphine use, you have to have a community provider working with you as a physician. Otherwise, you can't prescribe buprenorphine. At least that is what the rules are. And when we talk about, yes, sorry,
Doctor,
go ahead.
I'm seeing a lot of folks talking about Vivitrol, which is naltrexone, on the chat. And, you know, that is certainly a medication-assisted treatment. I don't, and Dr. Skinstad, I'm sure you're more up on the current research, but I don't think currently there's been any evidence-based showing that it actually extends recovery. Do you have any other more recent studies?
Naltrexone has been used a lot for treatment of craving among alcohol-dependent clients. And in the beginning, again, it was a very good results. However, in recent years, the results have been a little bit more mixed. So I think anything you use of medication-assisted treatment should be in combination with not psychotherapy necessarily, but support in the community, etc. Do you want to add? And I also want to say the community response and the use of community spiritual leaders, medicine men, often is as important as psychotherapy. So I'd like us to make sure that we include them as a very important part of our team.
I think it's also important to say, in our experiences, different things work for different people. So, you know, our philosophy is if something doesn't work for somebody, we try something else. We have used naltrexone with alcoholics very successfully. Other times it doesn't work at all. We've used it with heroin addicts successfully. Other people it doesn't work on at all. So we just have to, we keep trying until we run out and then we start over again.
Yes, absolutely. And I also want us to highlight the fact that a lot of people dependent on opiates also have and meet criteria for anxiety disorders, mood disorder, and we should not underestimate the suicidal danger of people with opiate addiction. Sometimes when we have worked with communities with a serious suicide epidemic, the suicides have been committed under the influence of opiates or alcohol. So I want to highlight that. And of course, we have physical disorders we need to worry about, such as HIV, STDs, and as we've talked about, overdoses. Do you want to add anything?
Well, I was just looking at if you have mental health disorder, before sometimes they're even diagnosed with that, sometimes it's good practice to speak to medicine people, healers, spiritual peoples within the areas that might be able to help with that and being able to determine whether this is something a spiritual experience or whether it is indeed a mental health disorder.
And I'm also seeing some comments in the chat here on tribal council being against medication-assisted treatment. I think that's a very, rather than being furious at it, it's a very important thing to remember that we need to educate our tribal council members so they understand. And I have worked with several tribal council members that may be in recovery themselves, and they have recovered a certain way. And in the old days, this was a substitute for an other substance, but today we need to think about it in a different way. And I have seen tribal council members being open to this, but they need education.
So yeah, and all this with cultural practices, evidence-based practices, you were seeing it today, and they're calling it best practices.
Yeah. Here are some suggestions for treatments that work. Motivational interviewing has shown quite good results working with American Indians. However, it has to be culturally informed. It can't be just the same way as it's done with other people. And the same with cognitive behavioral treatment, needs to be culturally adapted. I want to highlight motivational incentives. And I think drug courts use this, maybe not as much as they think they do, but praise, giving awards is a very important way of reinforcing sobriety. Motivational incentives can be in the form of a gift that works for a person with opiate addiction upon producing UA that is without any trace.
Very similar to the token economy.
Yes. And this is actually now possible to get support from Medicare. But I know that that Judge McGinnis wants to highlight some other approaches that have been used.
Well, I just wanted to add that in our court, for our wellness court, we do use a lot of incentives, and our court, it's the clapping court on Tuesday afternoons when we have our wellness court, because we use a lot of praise from the team and from the judge, myself. We also give a lot of certificates. It doesn't have to be huge things, and I know most courts don't have any kind of a budget to get actual physical gifts, but you can also get donations. But just even physical praise, verbal praise goes a long way. These are people who haven't been recognized for the efforts that they are making. And even coming to court is a huge effort sometimes for a lot of these folks, that they're actually showing up. And so at the beginning of their recovery, even if they show up 15 minutes late, I thank them for coming. I don't say it's great you're late, but I don't hold it against them that they're 15 minutes late, because next week hopefully they'll be 10 minutes late. And it's a progress. Yeah. Again, it's the baby steps. And we use moral recognition therapy, and that's an evidence-based treatment. But that's kind of expensive to go get trained in that. But there's also free CBT, cognitive behavioral therapy, like Seeking Safety, which you just have to buy the book, and then they let you copy that as much as you want to. So there are resources out there for doing cognitive behavioral therapy groups without having to have specialized training.
Mm-hmm.
Also, you might want to look at DBT, dialectical behavioral treatment or therapy. It was first made for suicide, but the way that it looks at life and the experiences and learning from them and seeing that it's worth living. It's like sometimes that itself, I've always thought that it would be work well with Native Americans.
I see a couple of questions here about SUD. I'm sorry, I used a acronym. It stands for substance use disorders. also want to highlight that we need to work very much with our self-help community, peer support, engage our clients in communication with their community, their elders. And we've seen in a study we did in one of our states that the people who did best after they had been in community corrections were the people who had connected with the elders in their community. And of course, in tribal courts, working with probationers, we do need to monitor. And that's also actually a very important thing as a feedback mechanism to the client. If somebody's values have gone down, if they have been without any trace for quite some time, that is a great improvement.
Yeah, and many times with the wellness court, they would like to do like 2 urine tests a week. So it's something that you don't just drop off. It's something you're going to keep going. And even if they're passing it, it also helps with giving that positive reinforcement as well.
And of course, it's important for having people succeed for them to have a structured daily life. So a lot of times it's recommended that you actually sit down with your client and say, so what are you going to do at 10 o'clock tomorrow morning? What are you going to do at 12 o'clock tomorrow morning? So job, education, volunteering, finding meaning with your life is something that I think is very, very important. And of course, we think in a holistic approach to healing. And if we look at that from the 4 directions.
So then we're going to be looking at the physical part, the emotion, your mind, and your spirit. Because we need to also look at what Native Americans is their belief system. So are they eating healthy? Are they treating their body healthy? Getting exercise? Emotional components, how are they dealing with their emotions? Anger, pain, fears, all these kind of things. But also with the mind, we need to give them resources and tools that they can use when they are feeling like using. And the spirit, of course, whether they're going to get back into the spiritual part or the traditional or medicine type ways within the tribes, prayer, things like that.
Mm-hmm. Mm-hmm. And we once in our center had a storytelling project for Recovery Month. And one of the things that we really highlighted that year was a guy who decided to start exercising. And of course, we know that exercising creates a higher spirit and produces endorphins. So that's the way he recovered. And whatever it takes is my attitude, and he did very well. And we've already addressed this a little. The challenging for us when we work with clients with substance use disorders is that they have, some of them, anxieties for getting pain relief because they know they are addictive. But our clients have a lot of accidents, as we talked about, and have fallen and do need pain relief, but not necessarily the addictive part. And here is something that I wanted to highlight. There are certain groups that are more vulnerable than others. And I want to highlight professionals in recovery, healthcare professionals who are close to dispensing of medications, pharmacists, people working in situations with terminally ill clients. I have had clients who had that problem, and that may have been the nurse, it may have been the physician, it may have been the physician, pharmacist.
So also looking at other professionals, we also need to look at secondary trauma. So gaining or getting some kind of services for them to be able to speak about that, to be able to get help themselves.
It takes a village, it takes a community. And what I'd like to switch over to now, I know Judge McGinnis is something she wants to also add, but I want to really highlight some of the projects that we have seen after our tribal symposium a couple of years ago.
Yeah, I just wanted to quickly say that getting folks together, getting the community to come out for a presentation or for meetings is really difficult. And one thing that we found works best in the Pueblo here that I work for is when the judge calls the meeting. So if you can get your judge to call the meeting, people tend to come, especially if it's folks who are the service providers in the community. They're going to respond to the judge calling a meeting more than other folks, perhaps.
Absolutely. And the 4 pillars of an action plan developed by ONDCP can give us some ideas of how to engage communities. And here you have the 4 pillars, and we will go some of them through them. And the beginning first pillar is really very important, and it relates to education and education of the community. And whatever community members you think will have response or be important to influence, you would like to educate about opiate addiction, to reduce crime, to influence the unborn child.
Help reduce stigma, help to get more support for the clients.
Yes. Mm-hmm. And here are who should be educated: the whole community. And Sean and I have on several occasions been in community meetings where the whole community gathered for a dinner, and we talked about different aspects with addiction and the importance of using any media, press, social media, communicate with professionals to educate the community. We worked with school personnel, healthcare professionals, and I want to highlight SBIRT, screening, brief intervention, and referral to treatment. That's a method that is important for all of us to really be familiar with. How do we early detect and reduce substance misuse? And how do we work with the community members to address their issues? Here are some centers, federal centers, that might be helpful to check into when it comes to education. And the treatment approaches that people need to be aware of should include all the approaches that we have already talked about, but I want to highlight the recovery community, the importance of self-help groups, aftercare, and use sponsors and recovery coaches. And if we look at monitoring, we know what that means. That means monitoring abuse and dispensing of drugs. And this prescription drug monitoring program exists in many states, and I don't know how often tribal communities use them, but as you can see at the bottom of the slide, the VA and the Department of Defense, of course, does not engage in this program, but Indian Health Service does. And if you look at monitoring, it means also recovering that these are relapsing diseases, and we need to have that in our mind when we will work with our clients and with people who are abusing. And we have talked a little bit about the Drug Addiction Treatment Act, which is part of monitoring abuse, and physicians who are given prescription privileges to prescribe buprenorphine will have a prescription waiver and also be educated to do this. This is also the third pillar that I think is very important, and especially if we think about how often some of the addictive drugs are diverted over to other people that shouldn't have had anything to do with this. It's in a community to think about how can we have days or an area in our community where we are able to go back and give back what we don't need. So people who are having children around do not have accidental ingestion of these drugs by children.
And also teens are very good at scavenging any leftover medications that you might have in your house or their grandparents might have. So, you know, the grandmas and the parents are the #1 drug dealers to teens simply because the teens are going into the medicine cabinet and taking all the leftover oxycodone and whatever else is left in there.
Yes. And there are some local medication disposal programs that I think would be important for tribal communities to maybe institute special days to do that. And then let's not forget enforcement. And I want to highlight this statistics up here. 325% increase in thefts from pharmacies and hospitals. That means that it's important for us to understand some of our pharmacists and hospitals are really vulnerable. And if you are in recovery, working in a hospital, you may be even more vulnerable for being forced to diverse. Okay. I am trying to get to the tribal programs that we worked with later on after our symposium. And here we have a program in Indiana in the Pojoaque tribe, and they worked on policies and a prescription drug monitoring program, and were very interested in enhancing communication between the prescribers and had good results.
Queenaw Bay Indian community in Michigan.
We looked at they looked at stabilizing treatments and delivering a treatment program, added healthy living, and expected their community members to give back to the community, and then enhanced graduation, and this was part of their drug court program. And White Earth in Minnesota developed a disposal program and did different things, and also combined it with enforcement and had very good results. And the Ho-Chunk Nation in Wisconsin looked at the chronic care model and developed a wellness team and worked very much on setting realistic outcomes and goals. And our Oneida Comprehensive Healthcare, which is a community we worked with also, developed partnerships, organized their community and treatment programs, and looked at provider issues and did a very comprehensive approach to their treatment program and their approach to opiate addiction. I know we ran through a lot of the last slides, and now we have the resources, but I was trying to just give you a very good picture of how some of the tribal communities we worked with were successful in implementing community-wide programs. Sorry,
Okay, great. Thank you so much. It was really important to us to be able to save some time at the end of this webinar for questions and answers. And we've had quite a few come through as well through the chat, and I know that some questions were addressed as we went along, and there may have been others that were not yet addressed. So we want to leave this time open for any burning questions that you would like to ask. And Jessica, you may have made some notes as well as I did about some specific questions that or areas that we want to bring up to be discussed as well. I'll bring one up. Kelsey Taylor had mentioned a question about the effects of SSRIs, abuse, and wanting to know about are folks getting high using these types of drugs, and maybe we can just open this to some discussion as well.
So Dr. Skinstad, you had mentioned earlier that folks were abusing the SSRIs. How does that work?
it's a good question. It is a little difficult to quite know how the effect, but getting a high, I'm not sure what kind of high it is, but it gives you distance to all the things you worry about, because as a psychotropic medication, that often is the result of using SSRIs. But how they manage is the abuse is higher than prescribed.
Right, so using more medication than is prescribed to create some kind of a effect in the brain. And that's with gabapentin too, where they'll take as many as they can put in their mouth and get a high from that. And also with even cough medicine, you know, in New Mexico, kids can go buy cough medicine and they'll glug the whole jar down and get high from that, from the dextromethorphan.
Another area that I've seen mentioned, and it's not a specific question, but there's been a lot of interest and discussion in the chat box about cultural resiliency. And I'd love for you guys to chime in about your thoughts on how the use of culture and connection to community is important in working with folks who have these addictions.
Okay, so then many times it's like having a culture from their background. If you've come from the tribe, normally on the tribal land, grow up there, you have this sense of belongingness. But many times it's like we might see some people who don't feel they belong. Maybe people who've come back, maybe in urban communities where they don't have that connection to their tribe. So many times it's kind of depending upon what they're going through, it helps to give them a sense of belonging and pride in themselves.
And I'm also thinking about the pride, I think, is very important, but also the sober social events that tribes put on. It's not just drinking and powwow and partying. There are ceremonies that have a very strong impact on your life. And I want to highlight one thing. We have worked with returning veterans, and what we forget is that many tribal communities have ceremonies for returning veterans. So when they come back, they are feeling included in the community, they are feeling respected, and they are feeling the pride. And I think that's very important, because cultural, I call it atrocities, with all the shaming on enjoying the culture, the spiritual way, the ceremonies, can be very difficult for people to recover from. And we really think that is a very important part of recovery.
And this is a very important concept when you're looking at trauma-informed care, because if people have been traumatized outside the tribe by either non-natives, they're going to feel that same kind of hesitancy or stress within people that are not from their tribe.
Mm-hmm. And I see someone here asking of our view on the use of peyote. And what I really think is very important is that peyote is used in ceremonies and in the Native American church, and it's not meant to be abused. And when it's used properly, you will not see abuse. It's the same as tobacco isn't supposed to be abused, supposed to be used in ceremonies. But of course, people abuse it, but it's getting back to the way that peyote and tobacco is used that I think is very, very important.
Yeah, there's kind of, I don't know, a disagreement, I guess you can say, within professionals. Because some will say, well, they shouldn't be using at all. It's like, maybe, for instance, if they are addicted to a drug or substance that are similar to it, if they go to perhaps a ceremony, with the Native American church, perhaps they shouldn't use it, because you don't always have to use that. But if it's part of their culture, maybe it's something they're going through. It also needs to look at culturally. But if you're looking at traditions, deep spiritual practices and beliefs, normally these will not be abused.
Mm-hmm. Mm-hmm. And we've seen that in other cultures as well. When alcohol is used ceremonially in very, very small doses, it will not often be abused either.
This is Gina. Another question came in that was, it's kind of scrolled up now, but that was a question about the sober living communities. And I know that's one thing that I've seen in non-Native communities, but we also are starting to see that, at least one, in Judge McGinnis's community. And I'd love for you to share a little bit about that.
Right, so last year we got a CTAS grant. I pitched it as a pilot program, and we rented 2 apartments, one for men and one for women, for sober living. And we do have them pretty full. And it's for folks who are either homeless or couch surfing or don't have a sober place to be, because some people's families are abusing, and they will never successfully be sober if they have to stay with their families. And so we were able to give them 6 months of living in this apartment rent-free while we work with them to get them back on their feet, allow them to save money to get a down payment for an apartment of their own, get a job. So it allows them to get stabilized without having the anxiety of where they're going to sleep or whether they're going to have to choose to be in a house where people are getting high or drunk when they want to be outside of that community. So we've only been going for about 6 months now. We've had tremendous success with a couple people, and we've had to kick people out because they're bringing their drugs of abuse into the sober living apartment, which is kind of the red line that I've drawn, is that, people relapse, yes, but you cannot bring your drugs into the sober living apartment. So it's a lot of work, but I think having a stable house is what has helped at least 2 of the people who are lifelong alcoholics be able to stay sober for the longest they've ever been sober in their adult lives so far, which is almost 6 months. So I think they're a good tool. I think we're learning a lot, and we're making a lot of mistakes, but it's really experimental for us at this point to see what kind of a difference it makes. But I think in a lot of communities, there's sober apartments in the, just north of us in the cities, and they're very hard, and some of the people who run them are not scrupulous. They're there to make money, and they don't really care if the person's using or not. So it depends on, we have intense supervision of our apartments. Our probation officer can go in there anytime, day or night, and search the entire apartment, and that's what people agree to do when they go into those apartments. So we're learning a lot, and I hope to report back in a year of how it's going. But I don't know if other people have experiences with sober living.
I want to chime in a little bit on that because I totally agree with you. And what I've seen also working with communities where the treatment programs are far away from where they live. And what are they going to do if they go back, as Judge McGinnis says? And I believe in providing stable, sober living and the importance of that for recovery. That being said, there may be some people who will not be able to live outside a sober house. And that's something that I think tribal communities and also communities outside of tribal communities have to grapple with. And that's the same as with a mental health disorder. You can't really expect some people to be able to live on their own, but they will have to be living in a protected housing environment.
Yes, whenever I'm, different places, I do advocate for transitional living. It's something that after they're done with treatment, they can go to there and stay there longer, and it is normally about 6 months. Help them to get a job, help them to get back and transition in the community. It'd be nice if many of the tribes had more of that, giving them job skills, giving them a sense of pride, something that they can do beyond use. And it does come up sometimes about people being discharged from treatment and they don't have a stable living place. That can be a little bit difficult because then you got to ask yourself, what about the care that you're supposed to be able to watch your client afterwards? Where are they going to go?
Right, and the people relapsing were the ones coming out of treatment and then not having a sober place to stay, and that was a huge lack in our community. So that's what we're trying to figure out, how to have that and maintain that, but maintain it safely for the folks who are in the apartment too, who are still trying to stay sober, even if a new resident is acting out. So it's a really difficult balance.
Well, thank you, everyone. We're just about at time, and I appreciate your willingness to share this great information, and just from watching the chat box. And we also have some other webinars that are going to be coming up in the future, such as psychopharmacology. We're looking at tailoring any kind of specific webinars and training really from the request of the participants as well. So when you fill out your evaluation, make sure that you share any comments that you have about specific training that you're interested in. I'd like to give you a couple reminders. One of them is next week, NIJA's National American Indian Court Judges Association is having their annual conference, and there's also training for clerks. So definitely an awesome event if you're interested. It's coming soon. We at NIJA provide training and technical assistance to tribes. And again, this webinar and others are an important way to really look at helping tribal communities, tribal justice as well, in ways providing good information and training and the support they need to really make those changes in their community and support their community. For more information on any training or technical assistance needs or requests, you can contact me at gina@nija.org. I've seen lots of great resources being shared in the chat box. If you send them to me, we can get them out to everybody. And I just appreciate everyone joining us today and hope you have a wonderful day.
Thank you.
Thanks, everybody.